So I still like to acknowledge the resources that I use to put these teaching materials together, the various resources, internet, YouTube, Leakbook, Barclay Review, Fitzgerald Hollier, and I shout out to all of them for making this a big success. And I don't take credit for what doesn't belong to me. You know, all their resources are great resources. And I also want to say that this visual aid is a supplement to your reading. It does not intend to replace your actual seek for knowledge. These are the main areas to focus on. I cannot guarantee that all the text content will come out from this particular presentation. I did my best to present the most important exam-focused content. You can study using the PowerPoint and go back for further details with your textbook. Reach out for any questions or clarifications. So I just want to talk about pharmacodynamics because some people have seen this in their test too, pharmacodynamics. So I want you to know that it's just telling you about what the drug does to the body. It does not change as a person changes. So it's what the drug does to the body. Why pharmacokinetics? Kinetics is what the body does. So look at it. The first one is what the drug does to the body. And the second one is what the body does to the drug. Okay. So that is it. The first one is what the body does to what the drug does to the body. Okay, DB. And the second one is what the body does to the drug. Okay, DB, BD. So however you will remember it, what the body, kinetics, just remember the word kinetics. So it's absorption, distribution, biotransformation. So whatever, elimination, whatever the body does to the drug, while the other one is what the drug does to the body. So just remember that, kinetics and dynamics. Then we are still talking about primary and secondary and tertiary prevention. We talked about it, briefly the last time, but I want to emphasize that the primary prevention is use primary to remember when you want to prevent something. So P goes for P when you want to prevent something. You want to avoid the problem. You want to avoid it from happening. So for example, immunization, vaccination, safety information. You want to minimize risk. For example, wearing of seatbelt, wearing of helmet, immunization, flu shot, all those stuff is your primary prevention. You want to prevent something from happening. Then your secondary is S goes with S, which is screening. So whatever you do to be able to dictate the disease, it helps to pick it up early. It's already there, you want to dictate it. So whatever you do, that is your screening. For example, your mammogram, your colonoscopy, all those stuff you are doing to screen for something. Your depression screening, your questionnaire, questionnaire and all that, whatever you are doing to screen for something, to find out something, that is your secondary. Then your tertiary is your treatment. It's already there. You already dictated it. So now you want to treat it. And you want to prevent negative outcome. You want to prevent worsening of the condition. You want to improve the quality of life. Like we said, somebody with intellectual disability, they are not going to get better. except by miracle. But whatever you are going to do, you are doing something to improve their quality of life. You want to avoid further complications. You want to minimize, or you want to maximize compliance. So whatever you are doing to make sure that the person's life is improved, or you want to treat, or you want to reduce negative outcome, that is your primary, that is your tertiary prevention. So for example, these are the ones that can confuse somebody if you're not careful. For A1C, A1C can be secondary, it can be tertiary. So it can be secondary if the person, for example, somebody comes in, this is their first time of you making the diagnosis of diabetes, and you want them to do the A1C. So this is actually their first time you want to dictate if they have diabetes. That is your secondary. You are screening for it. You want to see if they have it, if they are diabetic. So that is why you need to look at the wording of the questions, because the question can show, it can show primary and secondary, it can also show tertiary. So you need to pay attention to know if it's secondary, if it's tertiary. So if it is secondary, this is the first time the person you are trying to make diagnosis of diabetes. Then it is tertiary if it's an ongoing something. Somebody is already diabetic and we know that they are diabetic, and you want to check it like the way they are checking it, when they have a follow-up, it can be every 6 months, it's supposed to be every 3 months, but the person already have diabetes going on. You want to check it again and again. So that is now your tertiary. So you just need to know the wording of the questions. The same way, like I said, when you have HIV question can be primary, secondary, or tertiary. For example, primary, you are educating them to avoid premarital sex. You are telling them to use condom. So it can be education. You are telling them to use condom, which is prevention for STD. Whatever you are doing, that is the primary. So now you are suspecting that they are HIV positive. So what do? You screen all those screening tests, ELISA, Western blot, and all that, or the one we are using the antibody. All of them is now your screening. You want to find out more. Then the tertiary one is, the tertiary can be in different ways. They are taking those antiviral medication to improve the quality of life. You can also recommend them to go to HIV support group. So just remember, it can be primary, it can be secondary, it can be tertiary. So the same thing with aspirin. Aspirin can be primary, aspirin can be tertiary. Primary, before they have stroke. You want to prevent them from having stroke. That is primary. Then tertiary, they already have stroke, post-MI. You are giving them aspirin. So please, primary, secondary, and tertiary prevention care, you have to pay attention to just know what they are asking about. So another thing can be, which is the most accurate which is the most accurate indicator for alcoholism? Question like this, you need to know it. Which one is the most accurate? Is it when somebody, is the most accurate indicator of alcoholism? Is it elevated liver enzyme or positive response to 2 items on the cage, or elevated creatinine, or low LDL, HDL, and ratio? So if you choose number B, that is correct, because when you are trying to make a diagnosis of alcoholism, you are going to involve, you are going to ask them the following questions, which is the CAGE questionnaire. Have you ever felt, or C is cut down on your drinking, A is annoyed by people criticizing you for drinking, G is guilt about drinking, then E is eye opener. I constantly say that CAGE questionnaire is just secondary prevention, and you have to know CAGE questionnaire because they will always ask you which of the following is not included. So it's not included. Example might be, how many bottles do you drink in a day? Or some other things that are not included. But remember, cut down on your drinking, annoyed by criticizing your drinking, guilt, and eye opener. So your CAGE questionnaire, you will always see something on this. Remember that. So breast cancer screening should begin when? So pay attention to this. Breast self-examination always begin at 20 years. And you need to know about breast self-examination, because when do you tell patient, a patient comes in and they tell you that they want to do it, they do breast self-examination, but you notice that they are in their period or they are menstruating. What do you tell them? Do you tell them to continue? No. The answer is they need to wait 1 hour, they need to wait 1 week. So you need to know breast self-examination, 20 years. So they need to 1 week after their period or after their menses. So then clinical breast exam is 30 years. So these are the type of questions you need to pay attention to. Are they asking you about clinical breast exam? Are they asking you about breast self-examination? Those two are different. Then mammograph, 40 years. Then MRI, only for high-risk patients, and it will be annual. Okay, mammogram always start at 40 for high-risk people. Okay, then prostate cancer, when should you begin that? Digital examination, it always starts at 50, but remember, pay attention again, this is guideline question. For high-risk men, it's 45, but for highest risk men, so these two things can be a great confusion. High-risk men and the highest risk men. Highest risk men is usually your 40 years. And we say that highest risk men is, for example, somebody that is Black African American male, and also somebody that have maybe a family member, maybe the parents or the family member, yes, died of prostate cancer. So they are at high risk, highest risk. So remember, high risk is 45 years, highest risk is 40 years. Okay, let's continue. Then the next thing you need to know, most of the time, the first generation antipsychotic is not usually, seen. But if you still want to know it, it's good to know. But most of the time, the one that comes out is the second generation antipsychotic, which you must know. You must know that, because that is where we have our Zyprexa, Seroquel, Risperdal. So Risperdal, Seroquel, Zyprexa. So these 3 is the most common one. Zyprexa, Seroquel, Risperdal. We have other ones, but most of the time for the exam, Zyprexa, Seroquel, Risperdal, and Abilify is the most common one they will see in the exam. And it's very important that you know your second generation antipsychotic, because they are the one that causes weight gain and blood sugar. So people that, if you want to put a patient on second generation antipsychotic, you need to know that this increases the risk for blood sugar, which is hyperglycemia and diabetes. So sometimes they say, the research said in the past, there's always risk for cases of ketoacidosis, which is true for somebody that have diabetes and diabetic coma. But remember, hyperglycemia, diabetes. So what is the baseline lab, or what you need to ask the patient? For personal and family history, you need to ask them, do they have history of obesity, diabetes, hypertension? So whatever you are asking is based on what? Diabetes and hyperglycemia, okay? And you need to get the baseline weight, blood sugar, BMI, waist circumference. So your question in the exam will center on all these things we are mentioning now, like the weight. So the exam can ask you, what do you educate the patient on? Zyprexa, on Seroquel, on Risperdal, on Abilify? What do you educate them? The answer will be what? Weight, to check their weight, daily weight, okay? Then it can also be blood sugar, which is fasting blood sugar, fasting lipid profile, because anything about this hyperglycemia, diabetes, you are also worried about what? Metabolic syndrome. So they can also ask about the BMI, and they can also ask about the waist circumference. So all of them is very important to know, the waist circumference. So what are some of the side effects of SSRI? The side effects: headache. We have agitation, bowel changes. Headache, you must know for the exam. Then nausea, you must know for the exam. Then sexual dysfunction, erectile dysfunction, you must know, which everybody knows already. You must know. So what are the recommended pharmacologic treatment for generalized? So this is something else you need to know, the treatment for anxiety, generalized anxiety. So we know that SSRI is usually the first line of treatment. We have said it so many times for generalized anxiety, PTSD, PSTD, OCD, panic disorder, depression, anorexia nervosa. All of them, the first line treatment is SSRI. But remember, the first line of treatment is SSRI. The second line is your SNRI, which is your buspirone. Then the short-term one is your benzo. But remember, they can ask you about benzo, somebody with generalized anxiety disorder. You don't want to wait, because SSRI takes 6 to 8 weeks before it starts being effective. So you don't want to wait that long. You can give it to them while you give them short-term benzo. We don't give benzodiazepine for a long time. We only give it at least 2 to 3 weeks, depending on when the SSRI starts working. So remember that for short term, because they can ask you, first line is SSRI. But for the short term, it has, if it's specific telling you short term, then that is your benzo, because you want to have immediate effect. So a 69-year-old female patient reports feeling of anhedonia for the last month. What should be part of the nurse practitioner's assessment? So if you remember, under depression, signs of depression, there are all the signs of depression which we know: difficulty falling asleep, lack of interest, all of those signs of depression. But always remember this word, anhedonia, because that might be what will be in your exam. They're going to ask you, which of the following signs of what? Depression. Or which of the following is not, depending on how they ask you the question. But remember, anhedonia is the same thing as loss of pleasure, loss of interest. They might not use the word loss of interest or loss of pleasure, but remember, anhedonia is still the same thing. So when patients have this loss of pleasure, something they love to do before, maybe the person loves to hike, maybe the person loves to go to the beach, and when depression sets in, they start having lots of this desire to do what they love to do before. Then you have to screen them. That is the answer. Screen them for depression. Which patient is at highest risk of suicide? This is one of the questions you might see. Suicide question, which patient? And they are going to list like 4 patients, then you have to choose the patient that is at risk for suicide. If you see anything like 86-year-old male with chronic pain, or 86-year-old man, white, is usually white male, okay? Elderly male, white, they are more prone to suicide. Elderly, white, male, and non-person with chronic pain. Elderly patients and male are more successful when they attempt suicide. Those at highest risk are white male, 85 years or older. Symptoms in elderly that should be particular interest or concern to healthcare workers, because they are associated with what? Increased risks of suicide. They may have hopelessness, alcohol abuse, restlessness, insomnia. But remember, the group of patients at the highest risk of suicide. You will always see it in your exam. You will always see it in your exam. Okay. Elderly patients who are treated for depression with TCS, I said it before, TCS you have to know, because one of the TCS, they can put it in the exam and they ask you which of the following medication, or they will ask which antidepressant medication is under TCS, and they're going to list medication that is SSRI, MAOs, and TCS. So you need to know your medication. All of them is in that video. You need to know the ones that are TCS. You need to know the ones that are SSRI. You need to know the ones that are MAOs, and also your atypical second generation antipsychotic. All of them is in mental health. So this TCS, one of the side effects you have to monitor is arrhythmias. And it also causes anticholinergic effect. We have gone through this so many times. A patient will have anticholinergic effects, which is what? Dry mouth. constipation, retention, urinary retention, confusion, and even delirium. And we say that you need to know some medications. It can be, they can ask you over-the-counter medication you cannot give when patient is on TCAs. And we say that example is your what? Benadryl. You cannot give it to them. So you need to pay attention. Patients, the elderly patients on TCAs and patient need something for allergy. You are not going to give them Benadryl. Rather, you are going to give them Claritin, or you're going to give them Zyrtec. So no Benadryl because of what? Anticholinergic effect. So many medications for the elderly, you have to pay attention to avoid it for what? Because of anticholinergic effect. It dries up, drying up. Hypotension may also result, especially in the elderly, and we say that it may cause a lot of sleepiness and weight gain, hypotension, and it has to be used with caution because it produces bradycardia and prolonged. So don't forget this for TCAs. Don't forget it. So a resting EKG is necessary to start. So they can ask you, what can you start for a patient on TCAs? Resting EKG. Don't forget your TCAs as you remember your SSRI. SSRI, we have said it, and I said you need to remember SSRI, erectile dysfunction, headache, and nausea. Then you have your atypical antipsychotic, second generation. You have to remember weight gain, blood sugar. And I said anything that has to do with metabolic syndrome, like weight gain, blood sugar, diabetes, waist circumference, and all that, you need to remember. Then this one, TCAs, anticholinergic effect, bradycardia. So you have to be worried about it can produce bradycardia and prolongation of QT intervals. Don't forget that prolongation. So they might put the medication for you and they can ask you what is the side effect of this medication, or which of the following medications should you avoid. So you need to avoid anything that is anticholinergic effect. And you also need to know that it causes bradycardia, arrhythmias, prolongation of QT intervals. A nurse practitioner suspects that a patient is abusing ethanol. Ethanol is your alcohol. What laboratory values would support this suspicion? So you need to pick up the options that have these three things. When somebody is abusing alcohol, this is exam question, elevated LT, AST, and GGT. GGT is the most important. GGT is the most important because ALT and AST can be elevated in other conditions, but GGT always has to do with alcohol. So that is why it's very important. So liver enzymes rise in response to acute injury to the liver, ALT and AST. And you need to remember they can ask you if a patient have hepatitis, which one will be elevated? That is ALT, okay? L, you can use it to remember liver, anything that has problem with the liver. Then AST is if there's any injection when somebody eats. So you can use your A to remember aspirin, S to remember statin, and T to remember Tylenol. So these three three things. When somebody ingests or takes in statin, maybe somebody is taking medication for hyperlipidemia, all those your statin, simvastatin, and all those medication for hyperlipidemia, then AST will be elevated, not ALT. That is another exam question. ALT is for your liver, any damage to the liver, hepatitis, but when you ingest anything, then AST will be elevated. For example, if you are asked in exam, a patient comes in with right upper quadrant pain, and right upper quadrant pain, you are looking at two things. You are looking at hepatitis, you are looking at cholecystitis. But the difference between hepatitis diagnosis and cholecystitis diagnosis is that they would be specific. For cholecystitis, they will tell you patient ate a fatty meal, heavy fatty meal, and the pain is radiating to the shoulder. So they are going to be specific. There's a radiation in cholecystitis. Cholecystitis, there's always ingestion of heavy fatty meal. But in hepatitis question, they will tell you that patient have a right upper quadrant pain, but the difference now is patient have dark urine, patient have dark urine, abdominal pain. So they are going to ask you, they are going to tell you, and patient have aversion to smoking. So that means that patient do not like smoking. It didn't have to do with smoking, okay? It didn't have to do with something the patient ingested. It says aversion. Aversion means hatred, did not like, okay? Patient did not like smoking. So patient had aversion to smoking. So it says, which of the following labs will be elevated? The answer is your ALT, because you are looking at hepatitis. And it says that patient have aversion to smoking. So it was not smoking that caused it, because if it is what the patient ingested, then that is your AST. But if it's not what patient ingested, that is ALT, okay? Then the AST is usually the higher of the two enzymes and can signify alcohol abuse when it is more than 2 times greater than the ALT. In patients who abuse alcohol daily, the ALT and AST may be normal, like you said, but GGT, your gamma glutamate transferase, your GGT, is often elevated, okay? Even if the ALT and AST is normal. So that is why I said GGT is the most important. But in the exam, they are going to put the option that have these three things. But if they don't put option that have these three things, always remember to choose GGT. GGT is the most accurate for somebody that is alcoholic. Trazodone is a tricyclic antidepressant that can produce profound drowsiness. It is often taken at bedtime to induce sleep. So this medication should always, so that is the answer. When should you take it? This medication should always be taken at bedtime because of what? Profound drowsiness. And it's often given to treat insomnia related to depression or to alleviate the jilting and restlessness that is sometimes associated with SSRI and SNRIU. So most of the time, this medication causes profound drowsiness. You need to know that. And that is why they can ask you, what do you educate the patient? The thing you educate them is always take it at bedtime, okay? Always take it at bedtime. So they can ask you, a common side effect of trazodone may be alleviated by, So the profound side effect is drowsiness. So you educate them to take it at bedtime. So congratulations, you pass. So we said that the answer is acute epidermitis because there's a scrotal support brief. So when there is a relief, then that is your epidermitis. If there's no relief, that is your testicular torsion. Then this one, we said that relief of pain with scrotal elevation. So that is left-sided scrotal pain is our buzzword. He reports having intermittent unilateral testicular pain. So we are looking at in the past, but do not have a severe current episode. Confirmation of testicular torsion will include all. So except the patient will not have any relief with scrotal elevation. If there is relief, then that is prostatitis. If there is relief, then that is prostatitis. No, if there is relief, that is epidermitis. But if there's no relief, that is your testicular torsion. So we do the surgery. The surgery will help to prevent reoccurrence because testicular torsion is not really caused by trauma. So the surgery will help. So there's always the left testicle is always affected. The left testicle is always affected. So which test to determine whether the swelling is in the testis? So the buzzword here is the test, okay? And we use the ultrasound. The nurse practitioner recognizes that most common cause of epidermitis is your what? Epidermitis is your chlamydia. Because we say that if the patient is less than 35, then that is your STD. 25-year-old patient have fever, dysuria, low back pain. So the buzzword here is scrotal edema. So patient have other signs of UTI, but is associated with scrotal edema. So that is why the answer is epidermitis. If there is no scrotal edema, then that is your bacterial prostatitis. Most common gram-negative bacteria that causes both acute and chronic bacterial prostatitis is your E. coli. Please remember, E. coli. This is so common. This is so common. When performing prostate exam, you note tender, warm prostate. That is your prostatitis. So the buzzword here, you can see tender, you can see buggy. Okay, so that is your bacteria prostatitis. There is higher risk of balanitis in which patient? That is usually your diabetic patient, and immunocompromised. People that they have low immune system. Diabetes, then immunocompromised. Then let's talk about this. You perform digital rectal exam on 72-year-old male and find a lesion suspicious of prostate cancer. Prostate cancer. The findings are described as, is it robbery, enlarged prostate lobe? Robbery is your BPH.
No.
Then area of prostatic induration, okay? We keep that one for now. Then we keep that one for now. Prostate and Boggy gland. No, we say that is prostatitis. Then prostatic tenderness, which is still your prostatitis. So if you go with B, you are correct. So that is anything cancer. Cancer is usually described as what? Firm or hard, asymmetrical. Asymmetrical. And any in duration, that is your cancer. Lesions are usually asymptomatic with digital rectal examination, only done when suspicion is evident. All of the following can cause an elevated PSA level except current prostate infection. Yes, it can cause it. BPH, it can increase the level of the PSH. Any recent cystoscopy, yes, which is a procedure. Then prostatectomy, no. So all the following can cause it except, so because prostatectomy is the removal of the prostate gland, So every other thing, these three can cause elevation in the PSA, infection can cause it, BPH can cause it. When they want to take maybe biopsy, something like that. And that is why you need to look at your question very well. If they tell you that patient have infection, BPH on any of those things, and they put something about PSA. So if they have infection, for example, depending on the question you are asked, the answer can be to repeat it, to repeat it later, because it can cause increase in their PSA level. A 54-year-old white male with no obvious risk for prostate cancer. Look at the buzzword, no obvious risk. That is how I do it in the exam. I highlight the buzzword. It's telling you white male. That is a buzzword. Then age 54, because we are looking at something. To undergo PSA screening and digital rectal exam. The digital rectal findings are normal and the PSA is 3.7. So what do you recommend? If you remember, by teaching on this, you can be able to answer this. Are you going to repeat the PSA immediately? No, because this is 3.7. Repeat screening in 2 years? No. Remember, we said you repeat in 2 years if it's less than, depending on the book, 2.5, depending on the book you are using. Some books say 2, some others say 2.5. Okay, so if it's less than 2.5, you do it every 2 years. Repeat screening in a year? Yes, that is the answer. Repeat it in a year. If it's greater than 2.5, if you remember the PowerPoint, if it's greater than 2.5, repeat it in a year annually. But if it's less than 5, but remember, if it's less than 2.5, repeat it in 2 years. But repeat screening in 5 years, that is wrong. Okay, there's no guideline that says to repeat in 5 years. It's either you repeat annually or you repeat 2 years, or you refer for biopsy when it's greater than 4, or you refer when it's greater than 4. Then when it's greater than 10, they do biopsy immediately. Those are the 4 guidelines. The American Cancer Society recommends conversation between the provider and the male patient, 50 years and older to start for men at the average, we have said this already, risk of prostate cancer, and expect to live at least 10 years more. So PSA less than 2.5, testing every year, every 2 years, sorry, less than 2.5 every 2 years, greater than 2.5 every year, and greater than 4, refer. Like if they have 5, then greater than 10, biopsy. So that is why you have to pay attention to your PSI question. Your PSI question can ask you about PSA question can ask you about infection. Like I said, you need to know what causes an increase. If the person have infection, then you can repeat it later. If they have a biopsy, you can repeat it because it can increase it if there's any BPH. So you need to know that. And also you need to know the guideline. And another thing you need to know is if they are on Prosca, the Prosca, it helps to shrink the prostate. So if they're on Prosca, you are going to multiply by 2. So that means if your PCA is 3.7, for example, then you have to multiply it by 2. If your PCA is 2.5, then you have to multiply it by 2. Then when you multiply it, then it's going to change the guideline. So if the guideline says less than 2.5 every 2 years, then it's going to change it to what? Every year. So pay attention to questions like that. It can be so tricky, but if you know the guideline, you can be able to answer questions on PSA, sorry.
Can I ask a question on that?
Yes. So the action of 5-alpha reductase inhibitor in the treatment of BPH is to, just remember this, is to reduce action of androgen in the prostate. Just remember this in case you see the option, reduce action of androgen in the prostate. Harry has BPH and complains of some incontinence. Your first step in diagnosing overflow. And another thing you need to remember is incontinence. So many questions can come under incontinence because incontinence, they can ask you types of incontinence, which is your stress, another one is urge incontinence, and the urge one is the one that you have the morning of your exam or when you have an interview, you feel like to pee so many times, or I got to go. That is your urge incontinence. You feel like peeing so many times, especially when someone is under stress. That is your urge. You are under anxious situation. You have an exam to take. You came inside the exam hall and they tell you, drop your bag, put your phone in the lock, your system will change immediately. Immediately you come in and the exam environment, your head will feel like it's going to blow off if you don't have control. And that is how some people's anxiety start. And from there, you go to your seat, and from there, you turn on the computer to start your exam, and you're still going through some of those instructions. And now the exam says, if you are ready, click resume the exam. Oh my God, you feel like to pee again, except you tell yourself, I'm gonna sit here, I'm not peeing again. But outside that, that is the one you have, urge incontinence. And you have the stress one. Stress one is the one you do the Kegel exercise 10 times, and 3 times a day. Then that one, you need to know the Kegel exercise. Then that is the one that it is always associated with something going on. It might be that you are sneezing or you are coughing and pee is coming out. Or maybe somebody after natural delivery, like after delivery, it has to do with something that is your stress, incontinence. Something is causing it. Then you have your functional incontinence. It has to do with something that damaged. Maybe there was an accident, maybe something, but something caused it. It always has to do with maybe there is a stroke, whatever, but that is your functional. The person will lose the ability to be able to control their pee. Then the last one is your overflow. So many people don't remember that overflow is connected to BPH. That is your overflow, because BPH patients, they have a lot of urine retention in their bladder. So when you have that overflow of urine, that means they still go out to pee and they still have a lot of urine in there. They pee again, they still have a lot of urine retaining. So that is your overflow. So that is why it says your first step in diagnosing overflow incontinence will be to order. The answer is post-void residual urine measurement. Just in case it comes out for you, just remember that. A 63-year-old male presents to you with hematuria, hesitance, dripping. And this is another thing you need to know. Your BPH question, they are not going to this exam, they are not going to tell you BPH, testicular torsion. No. The exam will present with the symptom, because think about it. This is what the patient comes in to the clinic and they will tell you. Patients will not tell you, oh, I have BPH. No. But all the symptoms they are telling you, that is what the exam will present you with. So it's either after the symptom, the exam in the question might be, the exam question might be, what is your diagnosis? So you need to know diagnosis, which is after all those symptoms that is mentioned. And that is why you need to pay attention to the buzzword, because those buzzwords is what you are going to use to make the diagnosis. Then another thing might be, they might not ask you what is the diagnosis, but they might ask you what is the diagnostic, the finding, or to diagnose what you can use to make the diagnosis. A diagnostic test. So it can be like an ultrasound, MRI, CT scan, all those things. So whatever, or urinalysis. So whatever you can do. Then another question might be medication, treatment. Then finally, it might also be education. So those are the kind of things you might see. The education, what they are just going to tell you the symptoms, and they will ask you, what do you educate the patient? And another thing is, another thing you will commonly see in the exam is interactions. They're not going to tell you is medication interaction, but they want you to know. For example, they're going to tell you, like this is one of the ANCC question, a patient with hematuria, hesitance, dripping is already pointing at BPH. And they'll ask you a question and they will tell you, which of the following herbal medication will you recommend, or will you ask the person if they are taking? Then the answer is your what? Your sawpamento. So that is it. They will tell you the question, the signs, then it's left for you to know the answer. So this one is telling us that the digital rectal exam reveals moderately enlarged prostate that is smooth. The patient's PSA is 1.2. What is the most appropriate management strategy? So 1.2 is still normal. We are not going to refer. We are not going to start annual testing. 1.2 is still normal. So what do? The answer is prescribe alpha adrenergic blockers, which will help to relax. Remember, those are the ones that help the urine to flow, your flow mass. I didn't say force mass. Force mass is for the bone. You give for osteoporosis. What I say is flow mass. Just use the word flow. Flow mass. It helps the urine to flow. So you give the alpha adrenergic blockers, which will relax the bladder, then the prostate, smooth muscle to improve flow and relieve symptoms. So pay attention to this, please. Alpha adrenergic blockers. That is what you give. What differentiates prostate cancer symptom from BPH? The answer is symptom of prostate cancer in general tend to progress more rapidly. So everybody knows cancer has to progress more rapidly.